Harriet is a consultant paediatrician and fellow of the Australian Academy of Health and Medical Sciences, based in Melbourne. She is Associate Director, Research at the Centre of Community Child Health, Director of the Royal Children's Hospital Health Research Unit, and Group Leader, Health Services at the Murdoch Research Institute. She has many, many, many hats. And I'm not going to read all of them out because I'll take up most of her time. Her research focuses on developing, testing, and implementing novel approaches to keep children out of hospital, reduce low-value wasteful care, and integrate health, social, and education services to improve health and wellbeing for children, including those living with family adversity. She has published widely. She was awarded 10 of the best research projects for 2023 for her groundbreaking trials in sleep in children with ADHD and autism. Harriet has a strong focus and interest in translation beyond traditional methods. And for us and our challenge right now, that is an incredibly important topic. We are lucky to have Harriet join the Better Start Science Advisory Panel in 2022. Harriet, welcome to the stage.
Thank you, Wayne, and it's a real honour to be here, and thank you to the your team for inviting me, and Claire, what you said resonates across the ditch, particularly with our First Nations children and with the many families facing the rising cost of living in Australia. I promise there will be no rugby jokes because Australia's doing really badly in rugby. But can we move on to my slides, or do I just do next? Okay, research translation, it really is the holy grail. And I'm going to talk about what is research translation because there's many definitions and terms around which can make it pretty confusing. Some examples from my practice, some that have worked and some that haven't, and then leave you with some resources, some practical resources to use really from the get-go when you're designing new interventions or strategies, hopefully co-designed. I think this is one of the biggest problems I have faced. The status quo bias. You know, would you like a shovel? No, I'm fine with this spoon. This is how I've done it. This is how I always do it. Why do you want me to do it differently? So what is research translation or translational research? And as I said, there's many definitions. Research translation, knowledge transfer, knowledge brokering, knowledge transfer and exchange, etc. Probably one of the more useful definitions comes from the Canadian Health Services Research Foundation, where they talk about the interaction between decision makers, and that can be family, consumers, policymakers, and the researchers, that results in mutual learning through the process of planning, producing, disseminating, and applying existing or new research in decision making. So very much a two-way street, very much collaborative and multidisciplinary. But it's really hard to do this, and this is there's many reasons why, but these are some of the issues. Researchers, policymakers, clinicians and consumers often have different agendas. We certainly have different time frames. As someone who's run randomised controlled trials, you spend 3 years doing it, you push the button on your Stata, analysis, and you get a p-value. And you go, right, it didn't work after 3 years, or it did work. We have different language and we appeal to different constituencies. But hopefully I think we have the common goal of wanting to improve outcomes for our populations. So here's some examples of what I've done in some of my work and what's worked and hasn't. So the first one is called the Allergy and Community Trial. And we've had a rising prevalence of food allergy in Australia, particularly in children. And that meant that we had 18-month waiting lists at our Royal Children's Hospital outpatient clinic to be seen as a child and a family for food allergy, which of course leads to problems, and the general paediatricians working in the community weren't trained particularly to manage or diagnose food allergy. And because of this, what was happening is we saw that parents were using alternatives to diagnosing food allergy. They were going off and getting hair tested in their children. The children were having adverse food reactions if they didn't know what to avoid, or they were avoiding unnecessarily some foods, and this was impacting quality of life. So I got together with Professor Mimi Tang, who is the then head of our allergy services, and we said, rather than the hospital doing all of this, can we redistribute the model of care into the community, and can we start to involve GPs and general paediatricians? So we developed a... Is it going to go forward? Oh, there we go. We developed a pilot. So I think everyone in this room will know that you need to pilot something before you try and fully evaluate it or roll it out broadly. And we developed a clinical decision support program for community-based paediatricians to better diagnose and manage food allergy. And we piloted this with about 34 families who were waiting on the waiting list for 12 to 18 months at our hospital. And we trained around 12 community paediatricians in our model of care. And what we found was it was highly acceptable to the paediatricians. 80% of families chose to take up the model of care, and the paediatricians reported improved knowledge and competency in food allergy management. And 93% of families were satisfied with their care, with no safety concerns raised. So that was a really good sort of indication we could move beyond a pilot to a trial. So this is what we did. We did something called a before and after controlled trial, where we recruited a control arm first and then the intervention arm. And the control arm just got usual care. They sat on the waiting list at the Royal Children's Hospital to get an appointment with an allergist. But the intervention arm got the offer of going to see a paediatrician close to them in the community who we had trained. And then we did follow-up at 6 and 12 months post-consent with really high recruitment and retention rates. And the initial follow-up consults were done by community paediatricians with annual reviews by the GP or the paediatrician, depending on what the family wanted. And we asked paediatricians to keep a record of what they did in every consult, and the allergists did the same thing as well. The paediatricians, we chose them. They were working in areas where we were getting lots of referrals to the allergy clinic, and they had no formal prior training in food allergy. The training program was just 3 one-hour webinars. So this you can start to see might be a problem for allergists who have spent an extra 3 years training. So we did 3 one-hour webinars, but we had clinical decision support flow charts, and I'll show you one of those embedded in the in the training. And the general peds could go to that and work out what to do, when to order tests, when not to, and what advice to give families. And we embedded parent education material in those flowcharts so they didn't have to go to another website to try and find and print out something for the families. So do not expect you to look at this, but that's an example of our IgE-mediated food allergy flowchart and training. And we took the paediatricians through this, and we did case studies and we trained them in it. So our main outcome was time to be seen. And so what did we find was that at a median wait time, the intervention cohort who were in the community got seen in 2 months' time. The control cohort, 12 months' time. They're the ones who are still waiting on the waiting list. And at 12 months, we can see in this this diagram here that 75% of kids were still waiting on the hospital waiting list. So wouldn't you go, this is fantastic. This should just be rolled out to all the community paediatricians who want to train in this, because the other outcomes we had were the intervention families, the community families versus the hospital families had fewer adverse food-related events. They were more satisfied with their care, less food allergy-related anxiety, and there was no difference in the quality of care received. Now that really started to upset some of my allergy colleagues. So I would say, really did not succeed in translating this intervention. It's been allowed, I put in inverted commas, to be translated into our rural settings where the allergists who predominantly work in the city settings don't have enough reach. But the allergists, and we have a strong private system in Australia, which I won't go into my thoughts about that, but you can probably tell, they got really worried that we were going to take business away from them if we did this model. And we had a change in the head of the allergy department who passively and actively blocked translation of this. So my lessons learnt from this is just because something works and patients love it, don't expect it to be translated, and you need to keep on working with your relationships with key stakeholders. So that was not a success. Okay, so changing now to mental health. And this is COMPASS, Connecting Mental Health Paediatric Specialists and Community Services. So this arose during COVID. And this is data that we analysed of mental health presentations to Victorian emergency departments by children from 0 to 18 years of age. And we looked at data from 2018 through to October 2020. That grey area at the end is when Melbourne was locked down. We were the most locked down city in the world. And those green areas are the 95% predicted intervals for presentations to the ED based on presentations in the previous years. And what you can see is anxiety, self-harm and eating disorders are the ones that presented more to our emergency departments than that of what we were going to predict. So we were getting this absolute barrage of ED presentations for children's mental health, and it's not an ideal place to be for those children. I'd already done some work for 3 years, and this is one infographic to summarise 3 years of work, where I'd worked with families, with children and clinicians to say, what's wrong with our mental health system for kids and how do we fix it? And these are the problems, the challenges that they nominated, and I'm going to talk about one of the solutions because we've been trialling many solutions. But the first problem is, particularly families and GPs said, we don't know if it's a mental health problem or is it a developmental thing that a child's going to grow out of. Then if it is a problem, we don't know where to go and where to get help. There are long wait times and out-of-pocket costs, and we did a secret shopper study for this, and I'm happy to talk to people about that later, but it's a great methodology for accurately recording wait times and out-of-pocket costs to get a service. Care was fragmented, it didn't support parents and siblings, and there wasn't enough care. So lots of problems, but lots of opportunities for solutions. And Compass was one of these. So Compass is 5 monthly community of practice sessions held online for local GPs, paediatricians, psychologists and nurses in topics of their choice. So they co-design the topics. It could be self-harm, gender issues, anxiety. Coupled with that is the psychiatrist from our hospital, the Royal Children's Hospital, offering a primary and secondary consult service to the GPs and the paediatricians. And we ran this as a pre-post study, and we started in COVID, and we found improved clinician confidence and competence to manage child and adolescent mental health problems, reduced referrals to our hospital system at an estimated cost saving of $1 million per year, and decreased clinician burnout, because we did qualitative interviews with the clinicians as well, and they said having this community has really helped us survive managing pretty complex mental health issues in children without necessarily the training and support to do that previously. And it improved clinician knowledge about how services are organised, how to access, how to diagnose and how to refer children. And this is just a quote from one of our GPs who said, I had a particular young girl I was really worried about. She had self-harm and suicidal ideation. She'd come to the emergency departments, more than once and just been discharged, given a referral. The parents were under a strain. She was, had 8 referrals in place, and she was on numerous wait lists. But with this community of practice, this GP was able to utilise psychological strategies, start appropriate medication and support and education. And she said, I have no doubt without this, the outcome would have been very different for that girl. So I'm really pleased to say that 3 years on, Compass continues in the northwest Melbourne area, and we won a public health award from this for the Victorian government last year. It's also spreading to other areas in Victoria, and I think it's got real potential for rural areas because we have very little child mental health support in those areas. So my lessons learnt with this were co-develop your intervention, pilot, as I've said before, engage all stakeholders, particularly those who oversee the budgets, show return on investment, and I don't do anything now without a health economist involved. I think they're just crucial. And make sure what you design is feasible and sustainable. So we partnered with our Northwest Melbourne Primary Healthcare Network, which is funded by the federal government to commission services, and they have run all the admin support for our community of practice, etc. The next study I'll briefly go through is Remedy, or Reducing Medications in Infants study. And this was a multi-site study trying to stop unnecessary prescribing of acid medication for babies who had crying and sleep problems. And we co-designed it with parents and with clinicians. And we did it's not a randomised controlled trial, it's a pre-post trial across a number of sites. And we evaluated it with surveys, hospital administrative data, and patient file audits. And why this? Some people may know about the Royal Australian College of Physicians having a top 5 do not do practice, and this is one of them. Do not prescribe medication, acid suppression medication, to babies with gastroesophageal reflux disease. We also had pretty good idea of what may help, and we know that guidelines by themselves are ineffective in making change to practice. So this is data from a systematic review we published in 2018, looking at what works to change clinician practice. And it's really multifaceted interventions, which really won't be a surprise, but things like audit, education, and system change. We knew there were barriers to reducing low-value care, and this was on the clinician side and the family side. The clinicians, particularly the ones in red, these are the ones that came out in our interviews. I'm uncomfortable with not prescribing, not doing something. I don't know what the alternatives are, and I don't have time to have a big conversation with families. It's easier just to write a script. Families said they want more tests, but did they? But they were also very anxious about their crying baby and wanted more resources. So we, am I posting the right? We did an intervention, and there's several frameworks out there for implementation science, but I think the ACT framework is one of the most pragmatic and useful as a clinician. So ACT stands for what's your action, who are your actors, what are the contexts, what's the target, and what's your timeline. And when we put that into our model and our intervention, we had, for example, our action was stop prescribing acid suppression medication. Who were the actors? It was the hospital paediatricians. Context was inpatient wards, special care nurseries. The target was infants and their parents, and the time was every time an otherwise healthy baby was admitted with crying or sleeping issues. So, as I said, we did this across 4 sites. We had local champions at each site. We had parent, hospital and GP written resources. We had on-site education, management flowcharts. We had videos for clinicians that I taped with one of my fellows of how to do a good consult versus bad consult. And we had posters up for families. Is your child on one of these medications? Do you know there are alternatives? Do you know this can cause harm? So trying to bring the families into that. And we trained our clinicians in plan, do, study, act cycles. So did it work, this intervention? And with the caveat of it was a pre-post evaluation, yes, we saw a reduction in prescribing, an increase in the number of parents advised to cease prescribing, and increased parent knowledge that these medications can actually cause harm. So I think really what worked for this was having those trusted local clinical champions, consumer input, and clear receptor sites for our end products to think about sustainability. So they are guidelines, which is not going to be enough on its own, but they've gone into our statewide clinical practice guidelines, and they've gone into other guidelines in Australia and into the GP's primary healthcare network guidelines, the health pathways. So, thinking finally about some non-traditional ways of translation. And as I said briefly before, I'd really start off my life doing trials of sleep interventions in children, typically developing kids with autism, kids with ADHD. And along came Sam Holt, who's one of our entrepreneurs in residence at the MCRI. It's great to have an entrepreneur in residence because they come from the business world and they think differently. And he said, look, you've done 20 years of sleep research, you've published in some great journals and conferences, but families don't know what you've done. And we had developed an app and we'd piloted the app, and the app worked as well, but apps are expensive to develop and they're expensive to maintain. So he said, why don't you produce some books? And what we have done is we've produced a book for each evidence-based sleep strategy, but it's a fun book that empowers the child to want to take control of their sleep and improve their sleep. So we luckily got some good publicity when we launched, and we've sold more than 20,000 of these books. We've put it all on a website for families, which brings together these books, and we've got free audio books, we've got podcasts we've done for families and health professionals, and we've got PDFs that are free to download for families of the various strategies. So here's an example of trying to translate your work beyond the traditional, papers, conferences, etc. And really it wouldn't have happened without this entrepreneur in residence coming to me and saying, let's do this differently. The other thing that I do, I may work out by the end of this where to point this to change things, is I work half a day a week as the Chief Health Officer for a company called MatterWorks. These are a digital edutainment company founded by two women who used to work for the Australian Football League, so nothing to do with health. And what they do is they're taking our research from the Murdoch Children's Research Institute and they're putting it into very digital forward video, short bite, almost TikTok content to try and better reach children and parents and teachers. So our first piece of work, which is a mental health literacy program for schools for kids in grades 5 and 6, the last 2 years of primary school and the first 2 years of high school. And thinking about sustainability, we've partnered with Education Perfect, which are a New Zealand company who are also in Australia, who send out class lessons to teachers across thousands of schools. So we can reach millions of kids through this. And what we've done is we have used, not old people like me to deliver the messages, but here's Jasmine TXO, who's a 22-year-old with a really strong TikTok presence. So she is taking our research and delivering our messages. And you can, if you get these slides later, you can look at the videos. We've made sure that what we've done aligns to the New Zealand and Australian curriculum, so the teachers can pick it up and start teaching this and meet all their requirements in the classroom. And we have used, as I said, there's quite a few New Zealanders in here, young people with lived experience of mental health problems. So they are delivering the message, not us. And I'm really pleased that we started off with our basic module called Decode, and we've just received Victorian government funding from the Department of Education to do further work for culturally and linguistically diverse children and First Nations children. And we've just completed work with New South Wales government funding to adapt it for children with ADHD, autism and physical disabilities. So you can see the power of really translating your research in different ways and trying to work with distribution partners who are often in the business world to make what you do reach more audiences. Finally, I will check my timing, Wayne, I'm all right. Just leaving you with some resources that I've used along the way to really try and think about translation. And this was developed by myself and Professor Sharon Goldfeld back in 2013. It's our translation toolkit, where you do a brief research overview that you can take to stakeholders from the start of your project. You identify stakeholders and you prioritise them with a power and impact matrix, because you often don't have time to influence everyone. And then you look at the levels of engagement and what you might do. So this is a sort of pen and paper thing to start with. You think about, okay, who are my stakeholders, internal and external? What sectors are they in? Government, health, education, research, business, media? You're going to get the media involved from the get-go. What's their value to the role? How do you prioritise the level of commitment, and maybe some limitations if you can't do it all? So we actually go through as a team and start to populate this at the start of a project. And the power and impacts matrix actually comes from the UK. You've probably seen similar sorts of things, but you're really, if people have got high power and high impact, this top right quadrant, you have to actively engage them. If they've got low power, low impact, maybe they're people who you send out a newsletter to on a quarterly basis, so something fairly low energy. So once you've done that work and you've mapped your stakeholders and you've mapped their power and impact, then you can start to fill out your stakeholder engagement plan. And this includes what you might do setting up your project, running the project, and translating your findings. And some people will be giving you information, some people will be actively involved, that level of engagement is there, and then your engagement method will depend on that level of engagement. So it's a very practical tool for someone like me who had no idea when I started what translation was, to really, think about this in a methodical way. And finally, there's a link there for the resources for that translation toolkit. The Murdoch Children's Research Institute has also put together a planning impact toolkit, which you can look at. And I work with the Melbourne Academic Centre for Health, and we've put together a whole directory of resources around implementation science, including that ACT framework that I showed you before. And we've also got a number of webinars where clinicians have paired up with an implementation scientist to talk about their work and how they've tried to translate it with an implementation science lens. So they're freely available to look at as well. And I think that is it. Thanks. You said no questions, Wayne, but we could have a couple.
We could have a couple of questions. This is for you.
Thank you.
Now, for most researchers, and I'm generalising and speaking as one of them from an earlier life, is that we're not trained in implementation science or implementation, and it's a sort of a frightening area. As you alluded to at the start, we pivot off p-values and celebrating whether they're significant or not and publishing, and that's kind of the end of the journey. And we're not funded to do implementation research, we're not expected to do it, so for many researchers it's a new journey, and I think what you highlighted was all of the examples in which you have shown the challenges that you face in implementation, so thank you very much for that, Harriet. We've got normally, and I said to Harriet, with keynote speakers, you don't usually have questions, but we've got a few minutes. So if any of you have a burning question, there's a roving microphone. Sorry, I've changed my mind, Deborah. We do have a few minutes. If there's anybody who's got a one or two quick questions, Barry's popped his hand up.
And so's Pat.
And so's Pat. Right. Who's first? Pat, you've got the microphone first.
Thank you, Harriet. A great presentation. I'd be interested in a bit more information about how you linked in with the media company, because it seems like that was a critical step to actually moving on, and may well be something that's more widely generalisable, given that in New Zealand there's going to be a lot of media people out of a job shortly.
So that again came from one of our entrepreneurs. We have 2 entrepreneurs in residence at the Murdoch Children's Research Institute, which I think is a really novel way of thinking about research translation. So that was a spin-out company from MCRI. This particular person, James Dromey, knew these 2 women. He knew that they were not happy with their current roles and they were looking to do something different. So one of them is a business and marketing woman, Sarah, and then Kylie is a digital production. She's the creative. And so he brought them in to MCRI, gave them a tour and said, look, we've got all this research here. And they started to think about translation. And so that worked. And for about 12 months later, it became a spin-out company, and MCRI's got a 20% stake in that company. And I had been, this is sacrilege, a bit overrunning randomised controlled trials. And they said to me, come and meet them. And I met them, started talking with them, could see the potential, and they said, we probably need a chief health officer. Do you want to come and do that a half day a week? So that's what I'm doing at the moment. And, it's been great. We've just licensed that Decode program to the AFL to go into schools, because they reach 1 million children in Australia, the AFL, to do mental health literacy, and it's been repackaged as goals. And the people who are now delivering the messages are young AFL women players coming up through the ranks, and men who have got lived experience of mental health issues. So it's been fortuitous, but it's also been the head of MCRI, Catherine North, having the insight to have entrepreneurs in residence on our staff who hang out in the cafe at the Institute and get to know us and come along to our presentations and start to think differently about translation.
Barry.
The talker looks really good, thank you. One of the issues in New Zealand, and I suspect probably Australia as well, is the rapidly changing context of both the health services and sometimes within the universities, that people are changing roles so quickly.
Yes.
That how do you actually plan when in fact in 6 months' time there's going to be different people in those roles?
Barry, it's one of the banes of my life, and you can't. But you have to identify those roles in the first place, start that relationship, and then know, in the knowledge that 6 months later there might be someone else. But you have started that relationship, there's been a series of emails, maybe you've done a 1 to 2 page policy brief about what the problem is and what you can do about it. So I think preparing those materials that then can be taken to a new relationship are really important. The other thing I would say is, and this is learning from a colleague of mine, Professor Frank Oberklade, is who else holds the power? So he's recently been running a mental health in schools program that got really well funded by the state government. And I said to him, how did you get that up and funded? He said, I got the teachers' union on side. And the government, Labor government, was not going to say no to the teachers' union, which was really way beyond my political savviness. But they're always going to be there. They're not going to change. So that's how he got considerable amount of funding for his program. So I think you just have to keep at it. It's one of the most tricky things, I think, as a researcher, because we tend to hang around, but yeah. But you've got Claire here for 5 years.
And just to add to that, those relationships take time to develop.
Yes.
You can't just pop into somebody's
No.
office and you immediately have an effective functional relationship.
Yep.
And for some stakeholders, as you get closer to the community, they take time to develop.
Yep.
And in setting up the National Science Challenges, that was one of the issues. We were expected to hit the ground running. What should have been allowed was a year of lead-in time, which was relationship building, because you can't have those relationships instantly.
And I'd also say as consumers are your friend. So I'm a co-director of a chronic illness alliance called Child Unlimited, and it's consumer-led, properly consumer-led, and we're coming in behind as the academics and researchers. And every time we've managed to get in to see our health minister, or we even got to see the treasurer, it was because the consumer approached them and the consumer led the conversation. So that's been, not sure if we've changed anything there yet, Barry, but that's been really helpful to get at least in front of those people. Yeah.